And if you all could go around the room and introduce yourselves, please, that would be great. Yeah, maybe we'll call on folks. I have Rajiv first on my screen here.
Good morning, everyone. I'm Rajiv Lajmi. I'm the chair of the Applied Health Informatics Department at Stony Brook in the School of Health Professions.
Wonderful. Thank you. Sloan?
Good morning. My name is Sloan. I'm a physical therapist and I'm the injury prevention professional over at Nassau University Medical Center's Level 1 Trauma Center.
Thank you. Amun?
Good morning. My name is Amon Honda. I am the community relations coordinator from Fidelis Care, and I'm in charge of the Long Island and Queens South region.
Nice to meet you. Nadine?
Hi, I'm Nadine Wilches, CEO and founder of Mind Dark Health, where we reduce risks of mental and behavioral health disorders with technologies.
Thank you. Jillian McManus?
Hi, excuse me. I'm a program coordinator with Concern Housing, Concern for Independent Living, with the supported housing program. I'm also an adjunct professor at Long Island University for the mental health counseling and school counseling programs.
Thank you so much. Danielle Craig?
Hello, I'm Danielle Craig. I'm the medical program administrator for Suffolk County Department of Health, and I work on the CHOP report for Suffolk County.
Thank you so much. Kelly DeVito?
Good morning. My name is Kelly DeVito from Horizons Counseling and Education Center, which is an outpatient substance use program.
Thank you for joining us. Samantha?
Good morning, I'm Samantha Summers. I'm the Nutrition Resource Manager at Long Island Cares Food Bank.
Thank you. Nina Skolko?
Hi, good morning, everyone. My name is Nina Skolko. I am the Director for Community Outreach at Nassau County Department of Health, housed here at the Office of Health Equity and Resource Center in Hempstead.
Thank you so much. Dejan?
Hello, I'm Dejan Walters, and I work for the Cancer Services Program of Suffolk County, where we do free screenings for people who have no health insurance for breast, colon, and cervical.
Great to see you. Thank you. Patricia?
Hi, I'm Patricia Cooper. I'm the Chief Compliance Officer at Stony Brook Medicine, but I'm also the Subcommittee Chair of Health Equity and Community Partnerships.
Nice to meet and see you in person, Patricia.
Thanks.
Kathleen?
Hi, I'm Kathleen Emmett. I'm the Nutrition Program Manager at Island Harvest Food Bank.
Thank you for joining us. Dr. Mermelstein?
Hi, I'm Linda Mermelstein. I'm the Associate Director for Community Outreach and Engagement at Stony Brook Cancer Center.
Thank you. Harriet?
Good morning. My name is Harriet Gordon Adams. I am the Program Director for Medicaid Case Management, working with NADAP.
Thank you so much. Sarah Popovsky?
Hi, good morning. My name's Sarah. I'm on the Be Free team that's working at Cohen's Children's Medical Center, helping to make catchment areas on Long Island breastfeeding and lactation friendly.
Awesome, thank you. And I think Irene put her intro in the chat. If you're joining us from the phone, no need to introduce yourself if you are unable. Thank you for doing that. Irene, where did you I know where Irene is from. We meet Epic, Family of Human Services. And Janet Romeo from Epilepsy Foundation LI. Thank you for introducing yourself in the chat as well. Maddie is next on our screen here.
Hi, I'm Maddie McBillion. I also work for Horizons Counseling and Education Center.
Thank you. Wally. If you're there, we can always come back to you too. Josephina.
Hi, I'm Josephina Caravella. I'm a health education specialist at Stony Brook Cancer Center, Office of Community Outreach and Engagement.
Thank you. Chris.
Good morning. I'm Chris Hendricks, Catholic Health System Vice President for Community Outreach.
Thanks for joining us. Claudia.
Hi, I'm Claudia Elahi. I'm the Catholic Health Community Outreach System Manager.
Great to have you both here. I think we have a few more folks on the next screen. Yeah. Who did we miss here? Is it Kelly?
We missed, Wally, I don't know if you're.
Hi,
are you
good
there?
morning.
There he is.
Can you hear me?
Yeah.
Yes.
Hi, my name is Olawale Akande, Nassau Health Corporation, Population Health.
Thank you so much.
You. And Eileen, I think. Eileen Pelletier.
Yes, Eileen.
Hi, I'm Eileen Pelletier. I'm the program director of the Moore Foundation for Breast Health Education.
Thank you so much. Tan.
Hi, good morning, everyone. My name is Tan Pham, Community Specialist at Outreach, Substance Use and Mental Health across Long Island, Queens, and Brooklyn.
Thank you. Cindy.
Cindy Brown, I'm the director of the New York Coalition for Transportation Safety.
Thank you so much. We'll hear a little bit more from Cindy in just a bit.
Did we get Danielle Graves?
I believe, maybe we missed. Yes, Danielle Graves.
Oh, hi, I'm Danielle Graves. I'm a community health ambassador in the Department of Community and Population Health at Northwell.
Oh, excellent. Thank you for joining us. Is there anyone else who has not had a chance to introduce themselves yet? Please feel free to unmute yourself and do so. All right. A really wonderful group. Thank you all for introducing yourselves. So let's move forward here. So we just have today's agenda. Take a quick glance and we'll start going through this right now. The first update of which is that we already kind of covered. We have moved to a new location. We are just a few miles west of our previous location on Vets Memorial Highway in Hauppauge. Janine kind of mentioned our limited meeting space right now. So we are going to be working through that, and we do have a poll at the end of this meeting just to kind of gauge your preferences as far as future meetings, and see if, in-person meetings is something we should explore. So we'll get to that a little bit later, but just so you know, this is where we're located now. Want to talk a little bit about the Long Island Achievement Award?
So about a month or so ago, we attended we were awarded the Long Island Achievement Award, the collaborative was, from the public relations professionals of Long Island, and that is presented to a person or an organization that has worked to benefit, enhance, promote Long Island. And I thought about all the work that the members of the collaborative have done over the years and this whole collective impact model that we follow and what we all do in so many different ways through all the diverse programs and interventions that are offered. And I nominated us and we were selected. So I was happy to have a group of collaborative members there as guests at the event ceremony, particularly members who were at the very beginning before we even knew we were going to become a collaborative. It was wonderful to have them there. And it was just nice recognition, and we picked up a little press as a result of it too. So that's really kudos to everyone who's a participant, because I don't do anything. Everyone who's on this call works in their own way to advance the health of Long Island. Long Islanders, not Long Island itself.
So thank you all for making that achievement possible, really.
Yeah, it was great. It was really great. What else happened?
So now we're going to hear a little bit from Cynthia Brown. It's time for our member spotlight, the Executive Director of the New York Coalition for Transportation Safety. Cindy, can you tell us a little bit about the coalition and the work you do?
Yes, the coalition has actually been around since 1983, at which point in time they were founded as the New York Coalition for Safety Belt Use, because they were a collaborative, just like your organization is, of approximately 150 members who were pretty much in the healthcare business because they were trying to get the seatbelt law passed. The organization was actually founded by I believe it's the American Association for Automotive Medicine and the Medical Society of the State of New York. And they knew from data that they had collected basically from one of the founders being involved with aviation. They saw how beneficial seatbelts were for people who, used planes to get around, travel, whatever. So they really pushed it for cars. And the hardest part of getting it passed initially, or getting it promoted initially, was getting car manufacturers to even put a seatbelt in a car. But then when they did begin to get them in the car with these sort of offensive devices like buzzers and ringers and all that kind of thing to remind people to buckle up, people still weren't buckling up. So then the intent became to pass a law in all states that would require by law you to wear your seatbelt when you were in the car. This only applied to the driver at the time. It's since changed, but at the time it was just for the driver. And New York was the first state to pass that law in July of 1985, I believe. Oh God, I can't believe it's that long ago. But anyway, from there, several states, there are still states that don't have it as a law. In New York, it's a primary, which means you can be stopped just for not wearing your seatbelt. In other states, you would only be ticketed if you were stopped for a different driving offense like speeding. So, and then New York followed that up with the child passenger safety, which actually came first, I believe. And then backseat passengers, all people in the car basically now have to be buckled. And this effort was supported by the automobile manufacturers. And then eventually it was handed over to the states through their Department of Transportation. And it began to encompass other areas of traffic safety because they realized, or the state DOT realized, what a good effort, all these groups had put in and how successful they were with some of the changes they were able to bring about. So from there, I believe in the early 90s, we began to concentrate more on driver safety, pedestrian safety, bicycle safety, which was really hardly even thought of in the late 90s, but it's become a real issue today as more and more people do ride bikes or scooters or mopeds or stand-up scooters, any number of things. And because the number of people being injured by motor vehicles are not just inside the vehicle anymore. The years of COVID were the highest on record for pedestrian fatalities throughout the country. So we work with groups like the collaborative, but particularly with Brooke and Janine. And we try to put together programs on Long Island, which I'm sure Brooke will tell you more about, that aim to educate, the general public, all ages, about the dangers of, and particularly to the laws that apply to people who are pedestrians, bicyclists, and motorists. And you'd be surprised at how many people really don't even think about it. They're distracted, they're using their phone, whether they're driving, walking, running, biking, doesn't matter. Don't look where they're going, and wind up injured. And so, distraction is one thing we try to educate about. We try to work with other groups. We have worked successfully. Good Samaritan Hospital has been very cooperative in providing us with venues for press conferences and presentations. And we do all types of programs to try to involve the general public. We have a Facebook page. Brooke has established a website, Walk Safe Long Island, which I'm sure she'll tell you about. We do interviews, we do, public events, tabling events, all these kind of things, all in an effort to, save people from themselves, really, and other drivers out there on the road. So anything, Brooke, did I cover it?
Yeah, you certainly did. Thank you so much, Cindy. You segued perfectly into just a brief mention of the Walk Safe Long Island campaign that the collaborative works on in partnership with the New York Coalition for Transportation Safety. We actually just held our second annual Walk Bike Long Island Summit at Nassau University Medical Center. Big shout out to Sloan on the call today, who really made that wonderful event happen for us. So we just wanted to call that to your attention when you see us, talking about Walk Safe with a Duck, offering pedestrian safety programming. Cindy is the expert who delivers that education that we, coordinate and promote. So thank you so much, Cindy, for telling
You're
everyone.
welcome, Brooke.
Yeah, thanks.
Oh, there you are.
There she is. That's what she looks like. You're not driving, right? You're
no. She's
no. I'm actually parked. Now I'm going to get coffee.
Okay.
Walking the walk.
Yeah, because I caught myself a few times breaking some of the rules that I'm promulgating.
As long as we're mindful.
Yes.
We do our best. That's all we can do.
This is a great example. Cindy, I'm sure it took many, many months, maybe years to get that law passed. But it's an example of how, when collective impact, right, that coalition she had together, and having patience, we all get, I know I say this every meeting, you get so frustrated because change needs to happen, what needs to be done, but there's bureaucratic barriers, there's legal barriers, there's behavioral barriers, and it takes a long time. So when I hear stories like this, it rejuvenates you and makes you feel, okay, we can make a difference and get somewhere. So I appreciate that. And Cindy, these programs, right? I mean, they're all free through a grant from the state. She partners with anyone who's interested in bringing pedestrian, bicyclist safety information to their groups with whom they work. So
yes, actually, Janine, thank you for reminding me, because I should have said this up front. We are a complete not-for-profit 501c3, and all of our funding originates from the National Highway Traffic Safety Administration through a grant from the New York State Governor's Traffic Safety Committee. So that's where all of our funding comes from.
Yeah. Anybody have any questions for Cindy before we let her continue to drive? Her contact info, I guess, will be included in there?
Yes, you know what, I'll include Cindy's contact in these slides when I publish them online, and you can always reach out to me if you would like to coordinate something or connect with Cindy.
So thanks again, Cindy.
Thank you, Cindy.
You're welcome, Janine. If anybody wants a program, just use the contact information that Brooke has out there. I'm sure she'll tell you more about it. So thank you.
Thank you again.
You're welcome.
So next we have a little update about our core clusters. We have been meeting on a bi-monthly basis, really kind of working on individual projects, individual to the cluster. So before I go ahead and cover what we've been doing, is there anyone on the call who would like to speak to some of the progress we've been making on the mental health cluster? Okay, so we, at our last meeting, so the project that the mental health cluster has been working on is kind of a career guide to inform folks, who might be going off to college about all of the careers in mental and behavioral health that exist that they maybe might not have known about before. So at our last meeting, we kind of doled out certain deliverables to each participant, And when we come back at our next meeting on July 9th, we'll kind of be putting those pieces together, seeing how they fit and kind of determining our next steps. The biggest of which, after we finish the guide, will be a promotion plan to, you know, get it out there to schools, libraries, et cetera, to reach the students that we want to reach. And, you know, it's really of all ages. I mean, anyone could, you know, jumpstart or restart, you know, their career and pursue something.
I think what we plan to do is have a landing page about this.
That's the chronic disease.
Oh, that's chronic.
Yes, I know. There's a lot going on with these clusters.
So let me just back up a little bit for anyone who might be new or might have forgotten why we have core clusters. They're really work groups, but we call them core clusters because it's rather than say work group, we say clusters, because we don't want you to think you're doing a lot of work, which you're not. I mean, you are, but we try to take the bulk of it because, again, we understand this is a voluntary effort here that everybody is engaging in. So we have these 3 core clusters, and anyone's welcome to join. They're core groups that meet, as Brooke said, independently every other month. And they each have a project that they have defined and will have something tangible at the end of this year to share with everyone and to claim as their own and as part of the larger health collaborative. So that's the reasoning behind the core clusters, and we'll move on to the next one now. There's 3 of them, so.
Next one up is our chronic disease cluster. I will just put the same thing out there. If there's anyone on the call who would like to speak to the work we've been doing in that cluster, feel free. Otherwise, I can let everyone know. Okay, so we have been working on putting together like a landing page, like Janine said, with I know.
So much to do.
With a lot of resources for young adults who are managing their own chronic disease as they are maybe moving toward managing their own healthcare as well. So really, you know, between the ages of like 18 and 27. So really kind of providing them a page with a lot of helpful links. We'll have some general ones as well as some disease-focused links. So at our last meeting, we really kind of did the same thing where everyone took ownership of a different area of, you know, the guide, and we're going to be coming back together at our next meeting to put those pieces together and determine what else has to be done.
Yeah, and when you think about it, a young adult who may have a chronic disease, whether it's asthma or it's type 1, diabetes, or some of those other chronic conditions that are in colitis is a chronic condition, right? They have perhaps parent or guardian has been guiding them along, and now they're going off to college or whatever it might be, having to deal with the insurance companies, even though they may still be on their parents' insurance, but they want to start taking ownership and understanding how to talk to, you know, resolve problems with insurance reimbursement and whatever it might be. So it's like that. It's looking at, and it has lots of hyperlinks because we don't want to reinvent the wheel. But what we want to do is pull the resources together in one place and then obviously promote it as a spot. Probably use TikTok and places like that.
Yeah, all of our, you know, all of the channels that are available to us, all of our social channels, and really with a focus on that age group.
On that age group, yeah.
Which Alexis is probably going to assist us in some of that.
Alexis is of that age group.
Yeah.
Which I am clearly not. So we think that this will be a useful tool, and again, wonderful for that core cluster to take ownership of this. And then that extends to the entire collaborative. So next, shut my mouth now.
Well, no, thank you for that context. And the final cluster is focused on cultural competency and health literacy. I'll put the same thing out there right now. If anyone from the CCHL cluster would like to speak to the work we've been doing, please feel free to unmute yourself and do so. Otherwise, I can always give an update.
Hi, Brooke. I'll give you a break.
I didn't see you there.
So we're working on putting together a like a basic curriculum on, you know, what is health literacy and what is cultural competency and how can it be, applied in the field and how folks can incorporate that into their work. And our goal is hopefully to be able to offer some sort of continuing education credits for it and to offer it to organizations throughout Long Island to use as part of either their onboarding process or to use as part of their continuing education for their staff.
Yes, and it's all going to be virtual, and it's going to be a static module that is housed on the Long Island Health Collaborative website that anyone can take at any time. So that's what we're working toward in the CCHL group.
Yeah.
Thank you for that update, Josephina and Adesua. Thank you for.
And thank you for all the members of the group, those who are on all the groups.
Yes.
Or clusters who are on the call and those who are not, for all the work that you have been doing behind the scenes. It's really appreciated. Brooke and I provide administrative support and guidance, but you guys are the experts, so thank you.
And it's very exciting for us to see this progress that you've all been making.
Yes, it's very
So thank you for that.
satisfying. Is there any discussion, anyone wanna talk about what's going on with the clusters?
Or any questions you might have about them. And of course, if you're interested in joining, please feel free to email me and we'll add you to the group.
Okay, that means we.
Oh,
you got a question?
Hand raised, Dijon.
Hi, Dijon.
Hi. So I do have a question about the competency one. I would like to see, because I've been seeing a lot, especially here in our office, a lot of paperwork coming in where a client has signed that they understood specific things, and then when you talk to the client, they have no idea what you're talking about. And then when I go back to whoever did the paperwork, oh, well, I explained. Did you? I mean, you might have explained, but did they understand? But they signed that they understood, but they don't understand. Because, I mean, Cleo speaks fluent Greek. If she explained something to me in Greek, she did explain it, but I didn't understand.
Right.
So I would like to see some work done around that, whereas like the client has to recite back that they, what was said to them so that they understand. Because I am like, well, clearly they didn't understand because they're sitting here talking to me about it and they're wondering why. If they have questions, then they did not understand. So I would like to see some work done around that when it comes to competency or, understanding healthcare.
I will say the module that we're currently working on now is really more focused and aimed at providers and professionals and community-based organizations, but I think that's a really excellent idea to maybe have a reciprocal, guide or module that would be for the, patient or.
Yes, but I also think, and Adesua, correct me if I'm wrong, are we not touching on the teach back method?
I think I'm not sure if we do have that, but that should be included in cultural competence and health literacy. Is that definitely?
Yes, it is. Okay.
I worked on.
Yeah, because the heart of communications is you deliver the message, but is it received and understood? So that's how you tie that loop. So that is important for case managers, providers, program directors. Yes, you explain something, but did the person indeed understand? And oftentimes they don't. They say yes, but they don't. So that's a great point you brought up, Dijon.
And yes, glad that we've already incorporated it into our work with the cluster. Yeah. Thank you for that.
Thank you.
All right, so if there's nothing else about the clusters, and thank you, Dr. Mermelstein, for that note in the chat.
Yes.
Okay, just some updates about the community health needs assessment, community health assessment cycle.
Right, so for the hospital members who are on the call and the health department members who are on the call, you're well aware of the prevention agenda, which is the state's blueprint for becoming the healthiest state in the nation. It's a 6-year chunk of time that keeps renewing. We actually, the collaborative, going way back from our beginnings, that's how we came together, was to support prevention agenda, the prevention agenda priorities. We surveyed the community, found out what their needs were, the prevailing needs. Of course, it's always chronic disease, it's mental health, substance misuse. Those have been, that they rise to the top every time in both counties. And so those are our two driving priorities that are interwoven in everything that we do. Promoting nutrition, better nutrition, diet, and promoting exercise, right? Because those are the two ways that you can best have an effect on better managing chronic diseases or preventing chronic diseases, and certainly help with mental health and substance abuse. Many substance abuse programs incorporate a physical activity component as well. So I don't know what iteration we're up to with the prevention agenda. I think it started in 2013, maybe this is the third or fourth 6-year chunk of time. So the 6-year cycle, the next one is 2025 to 2030. Most of the states now are moving more away from disease-based priority and shifting towards the determinant of health, social determinant of health model. I have to say though, this collaborative, and those who've been with us for a long time will agree, we were talking about those barriers, those social determinant of health needs many, many years before they kind of became a buzzword now. So we always knew that if a person was living in poverty, or if they were not living in a home that was free of mold and other concerns, that it was going to affect their health and the outcomes, and they would be more vulnerable, particularly certain communities and certain geographic locations would be more vulnerable to disease, illness, injury, etc. and whatnot. So we've got a little bit ahead of the game. So it follows, right? So they're working on a new framework, right? They're kind of moving away, as I said, from the disease model. It's overseen by the Public Health and Health Planning Council. There's an ad hoc committee for the prevention agenda that works on this. So they surveyed, they've gotten feedback from the field. They are the consulting body for the ad hoc committee, is the consulting body for the prevention agenda. I am on that committee, and some of my colleagues may be too who are on the call. So just to kind of give you an update where we are at, and I have some late breaking news about that that just came in last night, which makes this slide a little out of date right now. But they did the survey. They're supposed to present the findings at the next Public Health and Health Planning meeting. What happened? The June 5th meeting was canceled, of the Public Health and Health Planning Council meeting. It's been rescheduled for July 8th. And that's the meeting at which the state proposes the new prevention agenda framework to the Public Health and Health Planning Council, right? So the State Health Department, the Office of Primary Prevention, or I don't remember the exact name of the office, which has oversight for this. They will, after all this input that they received, and also received input from a lot of community-based organizations, so I don't want to not address and talk about how important they are to this effort as well, too, because they are the ones oftentimes delivering those social determinant of health interventions. So they will deliver a new plan. They will deliver that a prevention agenda framework on July 8th, and then you can view that webcast on their website, and then the entire framework will be presented to the ad hoc committee on July 24th, with final approval by the Public Health and Health Planning Council scheduled for some time in August. So that's where we're at. So guidance for the new cycle is expected summer 2024. Well, the FIPIC is only looking at it and voting on it in August. It's probably going to be fall that we get the guidance, right? And of course, a comprehensive plan is due for hospitals, and the corresponding documents for health departments are due at the same time in December of next year. So there are many hospitals and local health departments already starting to put together and thinking about how they're going to work collaboratively to meet the needs and the mandate of this next prevention agenda cycle. And we here at the Long Island Health Collaborative, through many years since the beginning, the reason why I said we came together, have been serving as a backbone organization, both through all the local data collection, zip code level data collection we do pertaining to individuals and community members' perception of health needs, barriers, and some demographic information, et cetera. We've been maintaining that over the years and do an analysis every year, which is available to everyone. We will again be serving as a coordinating entity for the effort. And last time around, we had a subgroup, I think we called them the CHNA, CHA work group, something, preparation work group or something like that. And we met once a month, I think over the course of about 7 months. And then we looked at all our data, our qualitative data, our quantitative data. Last time around, I think we did some focus groups and key informant interviews for qualitative data. We've both on the CBO level and at the consumer level. We might do something a little different. Those on the phone might remember we did a summit, a CBO summit some years back. I'm thinking we might do that again since now everyone has gotten past the fear of COVID and is starting to meet. I'm thinking we might hold summits in one in each county for some qualitative data to add to what we have quantitatively. And then I actually write a template, well, not a template, I don't write the template. I use a template and I write the report, for one for Suffolk, one for Nassau, as you can use part of it, all of it, some of it, to inform your own CHA and CHNA, and then the subsequent community service plans that are really the interventions that hospitals are going to put in place, and the community health improvement plans known as CHIPs that the counties will list their interventions and what they're going to do to address those needs that were uncovered. So that is going to be forming, I would say, toward fallish. So keep an update, look out for that. And then we have a link to guidance in the timetable through December 2028, because in the in-between years, they ask for an update, the state does, and the hospitals and the counties have to go in through the e-commerce system and do their updates. Right now, I'll just kind of give you a little bit more about this. The state is thinking of moving, in addition away from a disease-based priorities, moving to a 6-year cycle. So having to do a full report every 6 years, a full CHNA and CSP and CHIP every 6 years as opposed to every 3 years. And they did solicit lots of feedback about that. Mainly, I think the benefit is you have more time to see if you've made a difference, right? So your outcomes and your metrics and your measurement may be more helpful and more realistic, but I don't know what they'll decide to do. Hospitals will still have to do the every 3-year CHNA and community service planning because of federal requirements. So it just means that every 3rd year, they don't have to send those same documents pretty much to the state. So,
and if there's anyone who was not part of our work group last year from a hospital or health department that would like to join us, please just shoot one of us an email and we'll be sure to add you to that distribution list.
Do any of the members from the counties or hospital members want to jump in and have, talk about this a little bit? I know, Chris, you're very involved in this process.
Yeah, and you summarized it perfectly, Janine. And it is always so helpful when you give us that sort of master template, and then we can tweak it for our individual hospitals to their strengths and ensure that we're meeting the community's needs.
Yeah. And so I'm sure Chris will be part of that work group.
I think I was just voluntold, right, Janine? Happy to join. Happy to join.
You chair.
Thanks. Okay.
And anyone from any of the counties, local county health departments, because I know this is a very important part of what you do. If you might want to chime in if you'd like.
Sure. I'm working on it for Suffolk County, so I'm already working with. Can you hear me?
Yes, it's Danielle. Hi, Danielle.
Hi. So I'm working on it for Suffolk County, and I've been doing some outreach already, trying to build relationships, because before it was my boss, Dr. Friedman, who was doing it. And so part of my job description as I came on end of last year is to work on it. So I'm excited to join in, and you can, yes, add me onto the work group, I suppose, as well.
Yes.
Excellent.
And I think do we have anyone from Nassau County? We thought we did.
Yes, I'm here, Nina Skolko.
Hi, Nina.
Hi, how are you? So I have not been part of this in the past. My colleague, Dr. Tavora Buckman, and I believe Selena Cabello are the experts and have been doing it for many, many years. And I have a good relationship with them and would gladly get involved as well.
Yeah, and this is not just, the work group is not restricted to hospitals and health departments. Community-based organization leaders need to be there as well, because they are vital partners, as I said, in delivering program service, particularly anything surrounding those social determinant of health interventions. So keep that in mind as well.
Yes, and we will see that CBO input regardless, whether that's through the summit, a survey, interviews, whatever we determine. But please join us if you would like to. We'd love to have you.
Yeah.
Alrighty. Just a little reminder about our community health assessment survey. These links are still live and circulating everywhere and anywhere we can post them. We continue to boost the links on social media. We have some, putting some money behind that to really every town on Long Island. We have, targeted, and we have all of these materials for you to use, QR codes, some signage with those QR codes, and some even social media posts, some copy for your newsletters, things like that in our Google Drive. If you cannot access the Google Drive, please let me know and I will send you the toolkit directly. And I do just want to call attention to the fact that our community health assessment, the analyses that are housed on our website on the data resources page, if you cannot navigate to that page, please let me know and I will send you the link directly. We're just undergoing a lot of changes on the back end of the LIHC site right now. So if there's anything you cannot locate, please just reach out to us and we'll send you that link directly.
Yeah, we're trying to streamline that site. I know we've been saying this for 2 years.
It's happening now, we
but
promise.
It's actually happening. We have met with the, what they call it,
our
webmaster.
Yeah.
We had a list of what we had to do, then other priorities got in the way because this keeps slipping back to the bottom. But this is definitely gonna get done. It's gonna be much easier to navigate. It's just kind of all over the place right now, so bear with us on that.
Yes. And just some ongoing engagement items. Please send us all of your, free events, resources, jobs, even, calls for folks who participate in research, any messaging you'd like to get out there to your fellow collaborative members, please send that to me directly, and Alexis and I will include it in collaborative communications. We also have our events calendar that is available for you to add any and all of your events to, and Walk with a Doc, Walk Safe with a Doc, as you kind of heard from Cindy, a little bit more about what those events entail. Please reach out to us if you would like to coordinate one of those.
Yeah, and I'm just gonna say something else about this.
The only other thing I had is that we do have these 2 walks coming up. Thank you so much to Odessawa for working with us on the Sunken Meadow one that's coming up. That's going to be a really unique one that talks about the estuary that is the Long Island Sound, in conjunction with Dr. Paranandi, who's going to be talking about health. And then we have another in October at Hempstead Lake State Park.
Is the September one, are we also talking, is that near the estuary? Is that the estuary?
Yes.
We're going to talk about the estuary and raise some awareness about what an estuary is, and I guess as it relates also to climate health and climate change.
And equitable access, to New York State parks, and, making sure that everyone enjoys the beauty, of these really beautiful places that we have on Long Island.
And we waived, the parking fee's been waived, right? We've gotten that waived, so if you don't have to have a pass, don't worry about it, you don't have to pay. And again, it's hard to get people to come out to do these walks, but we keep going. I have to say, in recent months, we've seen an uptick.
That is true.
Right?
Yeah.
And we've really been able to intensify our outreach efforts, and that's, I think it's partly due to the efforts of our intern here.
It really is.
Who's wonderful. And keep in mind, we also do pre and post survey to capture what people have learned at all of these events, which that data then is analyzed and you can use in the CHNA, CHAs, community-based organizations can look at it for whatever reason. So we keep that in mind, some way of measuring and getting some data out of it other than just saying 20 people attended.
Yes, yep, those attendance measures, the survey measures, and we'll provide all of that to the CHNA work group as well, and everyone, you know, on this call, that'll be on our website, so. All right, that now brings us to our presentation.
Yes.
Hannah Moore, our Director of Health Equity and Community Health, is going to speak to us. My training here. All right. Just let me share, okay.
All right, hi everyone. Like Brooke said, my name is Hannah Moore. I'm the new Director of Health Equity and Community Health with the Nassau-Suffolk Hospital Council, more generally with the Suburban Hospital Alliance of New York State, but also with the Northern Metropolitan Hospital Association. But because we're a Long Island organization here today, I will just be referring to my role with the Nassau-Suffolk Hospital Council. So I've been with the council now for about 3 months.
Oh, all of 3 months.
I know.
Feels like much longer.
What she has done in that 3 months is phenomenal.
So I just want to thank Brooke and Janine for kind of bringing me into the collaborative and all of the wonderful clusters. I've met some of you through the clusters. So just thank you for welcoming me with open arms and all my questions and feedback and things. So you will keep seeing me, but it's really great to be a part of this first general collaborative meeting to kind of get some scope of the organizations represented here today and also all of the wonderful work that you're all doing. So I'm really looking forward to getting or staying more involved with all of this collaborative work. So since joining with the council, my role has really been looking specifically at the relationship between the allocation of healthcare resources or healthcare services and you know, where it's located, the type of healthcare service, and its effect on our medically underserved communities. So really looking at health equity and public health at that macro level scale. Health equity has definitely been, like Janine said before, kind of a buzzword, a big topic of conversation in the last few years, especially after COVID. So being that this is the collaborative, obviously you all understand health equity, are working actively towards health equity, are familiar with the social determinants of health. But really when we were thinking about this meeting for this month, I was reporting back about a conference that I went to and some of the ideas that kind of came up through it. And we just decided to kind of report out on that. And then also some of the work I've been doing with what we call HEIA Complete. So with that, I will share a little bit about this conference.
You could use the arrows or you can click.
Oh, there we go. All right. So on June 11th, I was lucky enough to attend the 2024 Long Island Conference on Health Equity. This was hosted at New York Institute of Technology's Westbury campus, co-sponsored by the Nassau County Department of Health. And this year's theme was Building Resilient Communities, Navigating Paths to Health Equity. I know that there are probably a lot of people here who maybe went to it or helped organize it, were a part of the panel. I know, Nina, you're from the Office of Health Equity, so I'm sure you were super involved in this. And just bravo to your department for putting on such an insightful conference. I mean, I came back and was kind of discussing with Brooke and Janine, and they were like, okay, we're gonna have you report out. So, you know, anyone who was there or helped to organize it, if you do want to jump in, I think we have time for some discussion at the end, where we can kind of talk about maybe other people's feedback. But so I'm going to kind of go through the day and what really stuck with me. So what I really loved most about the conference was how comprehensive it was and how deliberate and intentional all of the agenda items were. You know, from the beginning of the morning where we're hearing from our health commissioner in Nassau County, our Nassau County Department of Health staff, of course, echoing the sentiments of our Suffolk County staff who couldn't be there. But hearing all about the resources available through the county, things like maternal health services, sexual health resources, cancer centers, Center, the diaper and formula bank, all of these things that as a lifelong resident of Nassau County, I had never heard of, I had not been aware of, or really I should say that I was lucky enough to not have to be aware of these things. That I was born into a situation where it did not require for me to go to the county and find these resources. And I'm sure that could be said for a lot of professionals working in this space who are able to kind of reach their professional standpoint now through a lot of the privilege that we had being born into the situations that we were. But now representing the communities that we are and being mindful of these resources that we really, really should be able to refer out to. Specifically for those who are patient facing or client facing, of course, that's you want to be able to refer them to those resources, but even just those who are, those of us who are kind of on that back end, being aware of it when we go out into the community and just engage in any sort of capacity with our community members. We got to hear from Health First, who discussed making affordable health insurance accessible for New Yorkers. Here on the screen, you see Dr. Brian Harper, who's NYIT's VP for Equity and Inclusion and the Chief Medical Officer, who did a really great job at looking kind of at the historical roots of poverty, and the first efforts to kind of address poverty, and then contextualizing that for what we see in our communities today, and how that has affected his ability to provide equitable care in different settings. He spoke about working with an HIV commission, cancer care centers, justice system settings. So it was really wonderful to hear from him, both as an administrative standpoint, but also as a medical doctor, and having both of those experiences and being able to really deliver that equitable care and improve the health equity of our communities in both ways. I have to say my favorite part of the morning was listening to the panel. I know I think we do have some of the panel participants on here, so bravo to you. This was really just an incredible group of individuals where there were different representatives from all sorts of domains of those social determinants of health. So people who represent nutrition, housing, providers around their education, people from school settings and other community-based organizations were all a part of it. And I love just how perfectly all of their work complemented each other. We keep saying over and over that addressing health equity takes a village. And so it was really great to see everyone kind of bounce off each other's work and really uplift all of the work that we're doing. And some things that I hadn't even thought of that kind of came up. I know someone who was there who kind of represented the housing social determinant of health, talking about some of the barriers that they face as an organization, that often that there's a shelter shortage. Of course, we're aware of a housing shortage. As a young person on Long Island, I'm certainly aware of that, but a shelter shortage and having to pay for in cash for hotel rooms, and it kind of brings up that that idea that poverty is expensive, and that these communities are facing that strain because of where they're allowed to build shelters, or where the community shelters are allowed to be. We got to hear from some, I believe it was Long Island Harvest, hearing about the importance of having culturally specific foods available for our communities, listening to what community members want to eat, not what we think they need to eat, trying to inform them on ways to make their meals healthier, but based on what they already cook in their homes, what they're able to cook, what they grew up knowing how to cook, and really catering to that fact. That was very insightful. And then even from the provider standpoint, looking at that really individual level, how body language can change how a patient views you as a healthcare professional and listens to the advice and to the care that you give, and how impactful that can be. So I really liked how the panel brought up that, again, that macro level, public health as it is public, but really getting down to that kind of personal and individual level, and really motivating kind of everyone who was there and was there to listen, making our individual impact. So that was really great. I really enjoyed the panel. And again, if you're on the panel and have other insights or other things that you want to bring up, I think we have time at the end for discussion. So the second half of the day was really interesting, and this is kind of what brought why we kind of thought maybe we should report out about this. So the second half of the day was the Community Action Poverty Simulation, which was run by the Nassau County Department of Health. So the poverty simulation is meant to offer participants an immersive experience that sheds light on social, emotional, and economic struggles faced by individuals living in poverty. So at the beginning of the activity, we kind of came into this auditorium or gymnasium, and everyone was given a character card. You were given details about their housing situation, their employment situation, if they had family, disability, and then you were also given directions on what kind of bills needed to be paid and what kind of obligations needed to be fulfilled throughout your month there. So it was 4 15-minute weeks meant to represent a month. So just for example, my character for my character card was a grandmother who had had a stroke and was paralyzed on half of her body. I lived with my daughter and my daughter's husband and their child. So before the activity began, the Nassau County Department of Health staff went around the room and kind of pointed out different stations that you'd have to visit throughout the month. So there's things like work, school, your doctor's office, pharmacy, social services, community action organizations, and other community-based organizations. The grocery store even, and that was kind of it in terms of like directions for the activity. And I remember thinking, oh wait, I don't know what I'm supposed to do, which now I kind of realize is completely intentional. No one gets briefed on their poverty before being born into that situation or coming into a situation like that. I will say that we were completely unsuccessful in paying any of our bills. I was left home because I couldn't really get around being that I had suffered the stroke and my family had to go to work. So I stayed home and tried to take care of any of the bills that I could, and I believe we paid for our electricity and our rent, and that was pretty much it. We forgot to eat the entire month that we were there. We did not go to the grocery store once. We even at the beginning of the activity, you're given 5 transportation passes, and you need a transportation pass to get to any sort of station. So going to work required 5 transportation passes. We did not think it through. We lost all 5 of our transportation passes at the very beginning of the activity. So really thinking about how all of these translate to real life. So what the Department of Health really did a great job was explaining that this isn't a game, that this is real life, this is everyday life for many of our community members. And then afterwards we had the ability to kind of discuss what our takeaways from it were. And some of those, the first one I will say, I believe was about the overwhelmed social services department. There were long lines there, people were confused about what they were supposed to be getting there, confused about applications, and there was a lot of frustration. You could actually hear kind of people like fighting in that corner of the room. And just thinking about how that translates to how people are able to get the services that they need. One individual actually brought up the fact that you were able to buy a gun or buy substances throughout the game, or I shouldn't say the game, the activity or a simulation. Someone was walking around who was offering substances to individuals who would steal money, or like if you left your house unattended, they can go in and take like your microwave, things like that. And thinking about how that is true in real life, and the fact that, of course, we were stressed during the game, but not stressed enough or not fearful of our safety where we would have to buy a gun in some sort of fictional setting, but in real life, thinking about how people might be inclined to buy a weapon for their own safety. I can tell you during this game, I was like, I could use a drink after this. And you can imagine if this is fake, what about the people who are really facing that stress every single day, and how that might lead to substance use or problematic substance use in the future. One of the last takeaways, because I think we can go on forever about what people got out of this, was that no one attended their doctor. As a stroke patient, I was supposed to visit my doctor. I didn't go.
She had no transportation.
We had no transportation. My daughter in the simulation got sick with the flu and was not allowed to go to work. She was meant to go to the pharmacy, could not get the medication. She didn't go. So thinking again how that relates to our work in the healthcare field and all of these stressors and reasons why people can't get to their appointments, can't get to the pharmacy. Of course, I don't think any public health professional was coming to this, or anyone in the healthcare field was coming to this conference with the expectation that poverty isn't a big social determinant of health. But I think this really did a great job, like that quote says, of shifting it away from thinking of it as a personal failure or even just some sort of like personal like bad luck or something like that, but really understanding this as like an infrastructure issue, a structural failure of society. So I found that was a really great activity. Of course, this kind of made us think about like, oh, what can we do with the collaborative with something like this? If you are interested in it, I believe it's called the Community Action Poverty Simulation, and you can find it at povertysimulation.net. And you can also reach out to the Office of Health Equity. I know, Nina, you're on here. I don't work for the Nassau County Department of Health, although I feel like I could be their spokesperson after this if you're interested. But really, it was a really great activity, and I think it would be perfect for some sort of community settings where, of course, we're all health professionals. We kind of are able to conceptualize this, but maybe in community settings for individuals who are not so aware of all of the social determinants of health and the things that influence our health and poverty being one of those major factors. All right, so lastly, I just kind of want to talk about my role with the Nassau-Suffolk Hospital Council, which is really with HEIA Complete, and this is thinking about health equity again. As many of you are aware, in 2022, New York State implemented a new law that any sort of project that requires a certificate of need application, a CON application, so whether that be adding beds or taking away beds, relocating services, at a certain threshold requires a health equity impact assessment or an HEIA, and hospitals now have to employ an independent entity to undertake that assessment. So a lot of this is project scoping, where we're really doing a deep dive in the data that's available to us about medically underserved communities, and being able to understand their health needs and how a project that's being proposed might affect those health needs, and compiling that at the end into a data-driven narrative. And this goes to the state with the hospital's certificate of need application. But the reason why we bring this up today is that second step of the process, which is our community engagement. So a lot of this is talking directly with community members to get an understanding of their opinion or their insights on the proposed project, but also hearing from community-based organization leaders, departments of health. You might have gotten an email from me in the past, and you can bet that you probably will get another few emails from me in the future. But really, we're reaching out to get your insight on the communities that you serve, and I think that's incredibly beneficial. This is a way for you to lend your voice to your community, and we can kind of compile that and advocate for your community in a way that the project, the proposed hospital project, fits the needs of your community, or at least addresses how they plan to address those needs. So you will hear from me. I'm sure you've already gotten those emails, but as more and more projects come through, I will be around. If you have any questions about anything that we spoke about, again, some of the conference questions might be better directed to Nina or anyone with the Nassau County Department of Health, but otherwise, anything with HEIA Complete, my email's here, my phone number is here, and thanks for listening.
Yeah, thank you so much for that really comprehensive presentation, Hannah, and it seems like it was time well spent.
Yes, absolutely.
On your behalf, and as Hannah said, when she talked about that poverty simulation, it ticked off some thoughts in my mind about what we as collaboratives might be able to do as an activity. Not necessarily that same one, because I do know that there's a cost component to it and it must be evidence-based, but maybe something similar. And that kind of dovetails, and I guess we can have a discussion about this at a later date, because I don't know how much time we have left, but kind of dovetails a little bit with, I feel like I want the collaborative, all of us to engage in some kind of a research, Long Island-based research project. I don't know what it is, I don't know what it's about, but I feel like there's so much intelligence and talent and experience that we could draw from, that there is something in the health equity, public health, community health space that we could work on collectively as a research project. I don't know what it is yet, so. But when I saw the simulation, that was, I said to myself, we might be able to do something like that, and maybe something research related would come out of that. So just kind of tuck that in the back of your minds, because I'll probably revisit that next time around, because I don't think we have how much time we have left, but maybe we can. But if anyone, if you wanna, you know, Nina, anybody else who might have also been there, or if you weren't there and wanna discuss what Hannah just talked about, and what I'm thinking of doing, please, we welcome all ideas, we need ideas. Jump right in if you have anything to say. Okay, Patricia.
So how long did this simulation activity last?
So I believe they had blocked off 3 hours in the afternoon for that. Nina, you might be able to speak more to that, but the actual activity was about an hour.
Okay.
Yeah, the simulation itself is supposed to mock 4 weeks. And basically we did that in 15-minute intervals. So it is like essentially an hour, but you want to block off a lot of time afterwards to kind of debrief the situation.
I think it sounds like a great exercise, so thank you.
Yeah, I feel like we should, I mean, I don't think we don't have 3 hours to do something like this, but I feel like we could maybe, and I know Hannah's been looking into some other programs or evidence-based programs, but we could also create something of our own, and maybe that's our research. I don't know. But think about it.
Odessa hand raised.
There she is.
Hey, good morning, everyone. I definitely echo what Hannah mentioned in reference to the entire conference. So I was one of the folks that was on the panel representing the Suffolk County Health Department, and the diversity in knowledge of addressing health equity and how we're doing that in our different disciplines, but also the importance of how we're working together really resonated with me. And it was really exciting to see Dr. Harper. For folks that don't know, Dr. Harper was our former health commissioner who actually championed us having an office of minority health in Suffolk County. So we have a long history. And then in reference to the simulation, what I did love about it is, so I participated in one with Hofstra School of Nursing. So I got to see students do this, and then also seeing health professionals. But after the simulation, they actually reach out to you to ask you what your thoughts around the simulation and what did you not see that they could involve in the simulation. So they actually get feedback from folks who participated. And it's very telling, but it also really demonstrates the importance of us practicing with culture humility, because if you do not understand what people are enduring every day, it's very easy for us to be gatekeepers and for us to kind of shame people without recognizing the stress that they go through trying to meet their basic needs. So
yeah, I think it's a dose of reality, and for us, we know it's temporary, but for the individuals living it every day, it kind of humbles you and level sets you.
Odessa, your part on the panel was just incredible. I came back to them and I was like, oh, Odessa was on there. I know, just working through the CCHL cluster. So just great job. And it's always great to hear from you.
Thank you so much.
Anyone else like to chime in? No? No?
Alrighty, well, you all have Hannah's contact in case you do have a thought you'd like to share.
We got, what time is it?
I know, it's 10:47.
So you
not even
actually
11
got
yet.
some time back, unless you wanna,
Oh, I did just have a poll
Oh,
about
alright.
future meetings.
okay, sorry.
No, it's okay. These are the next ones we have scheduled for the rest of the year. And then, so we've kind of been, thinking about this moving forward. We'll have, maybe one meeting a year in person, some virtual. Just because this technology we have here to make the meeting hybrid is not something that we can take with us. So we just kind of wanted to pick everyone's brain and just kind of see, if hybrid is not an option, what would you prefer? And of course, if you have another idea, please feel free to raise your hand or put your thoughts in the chat. Curious to hear what you all feel and what you would like to do moving forward. Options I had: virtual, in person, a mix of both, or other.
Yeah.
I'll just leave it open for maybe, 10 more seconds here, if you wouldn't mind just answering. Thank you so much, Janet.
Take care, Janet.
Still getting answers. Yeah. So it's looking like either virtual or a mix of both is the overall sentiment,
Which
so.
is kind of what we thought.
Yeah,
But now we have evidence.
yes, now there's evidence, so thank you all for that. Alright.
So, yeah, so it looks a little more virtual, was a little bit ahead of the game here on the poll results, but a mix of both isn't far behind. So that tells us that until we can, well, I guess we do virtual and maybe have a grand meeting, a summit meeting, maybe in December, kind of as a wrap up. That's where all the clusters can then maybe personally present the products or the services that they were able to design. We started last year presenting a Community Advocates Award to a collaborative participant who has really gone above and beyond, and we'll do that again in December. So it might turn into something like a kind of a showcase and a celebratory meeting is kind of in my mind.
And I do just want to thank the folks who have reached out to us offering their office space, for us to have the meetings. Thank you all for extending that to us.
Yes. And I'm happy to, since we do have a little time, if anyone wants to talk about my idea of some kind of a research project or how we might go about structuring some, maybe not exact activity that occurred at the poverty simulation, but how we as a group might design an activity or something that we can participate in, understand, gain some knowledge, and then talk about and do a debriefing and maybe fold that into some kind of a research project or case study or a best practice that a collaborative engages in. That's kind of what I'm thinking. Maybe that's what I'm thinking, a best practice that we would be able to maybe get published in some kind of peer-reviewed journal, and then everyone gets credit for that. So I'm looking for all the light bulbs to turn on right now. So if they're not gonna turn on right now, when we do the summary, this is obviously going to be in the summary. And so I want you to start thinking about that. Maybe we'll send you a prompt. Kind of just, oh, Nadine has her hand up. Go ahead, Nadine.
Oh, okay. Thank you. Well, it was great to hear from everyone today, and that was a great presentation. It got me thinking. I wonder, Janine, I think that's a great idea to work collaboratively on a research-based project. Could, perhaps we could think about building on that structural failure idea.
Yeah.
Considering, for example, there's 9 research-based factors, one of which is economic disadvantage. So could we build on the structural failures in population health and then leverage that to bridge the gap into best practices with everybody's expertise and also resources that we have here on Long Island.
Okay, so that's the germ of idea, and I knew Nadine, you would come up with something, because she's so great at that. And that's, okay, so that's one approach. Anyone else have any? It seems to
Sorry. Okay, so two things. Just because all of this keeps coming into the office like literally like yesterday. So again, I would like to see how much particular medical debt is due to people not understanding what they signed. So I would be very interested in seeing those numbers. Also too, I would like to know like where our overlap lies in the people that we're servicing, because a lot of times people, you know, go to different organizations for different things because we all do different things. But oftentimes people fall in the gaps because I'm like, oh, such and such has been helping them, and you know, we kind of just leave it at that, and then they kind of get like stuck in this rut. So I'd like to see you know, how we overlap and if there's any missing pieces on us working together to help a particular individual. So I'd like to see something like that, like I don't know, like a unified CBO database or, you know, organization database where we can see what services they're receiving from each other, and then, you know, kind of fill in the gaps as needed. I'd like to see that.
Okay. I think that might sort of be coming when the 1115 waiver gets underway. I believe the Long Island Health and Welfare Council is the, what do they call it?
Social Care Network
Social
lead.
Care Network lead. So I don't think they're on the call today, but I can reach out to Lori there, and maybe there's something, this kind of an offshoot of what they're doing. So thank you for bringing, you know, talking about that, Dajon. Anyone else have any suggestions?
I did see Dr. Mermelstein's hand raised before, but it's not now, so if you.
No, it's okay. I was just gonna say that I'd be interested in participating in any of those projects, and we have, you know, some expertise at Stony Brook in terms of like, you know, analyzing data, that kind of population science, that we could kind of look into doing something like that. So I'd be happy to, if you're gonna put together a committee or a team or something to talk about coming up with a project, I'd be happy to participate, please.
Okay. Yeah, it would be, we would talk about it, it would be it would be collaborative driven, it would be, we would want everyone on a collaborative on board. Yeah, I forget. So we have to come up with a pointed research question that we want to answer. So these are good ideas to start with.
And I'm sure we'll be back in touch about this before our next meeting.
Yeah. But I feel like we should do that. I feel like we should do this next year. For some reason, I feel next year is the year we should do this. I don't know why.
Seems like a good idea.
So, and we got some really great people to work with. Anyone else? No. Well,
alrighty. That brings us to the end of our meeting.
Here we are. We thank you all for your, what time is it now? Oh,
10:55.
All right, half
35
hour.
minutes to spare.
We got some time back, at which we're always happy to give you back some time in your day. We're always here. Shoot us an email, give us a call. I think we respond as quickly as we can. Alexis, Hannah, anything else you want to add, Alexis?
Oh, well, the next newsletter is Monday, so if anything pops in your head about you might want to just throw at us, I'm updating that today, and Brooke's gonna work on it before we send it out. So if you have an event or an opening, please feel free to send it over.
Thank you for that reminder.
Yes, thank you. Hannah?
Nothing for me. I think you guys heard enough from me.
Okay, Brooke, anything else?
No, just thank you all for your time this morning as always, and we will be back in touch.
Am I missing anything?
I don't think so. I don't think so. A lot of really good insights in the chat though. And if I didn't directly respond to you in the chat here, I'll definitely follow up with you via email. So thank you.
You know, appreciate it. Like I always say, I don't like to hold a meeting, bye, Jessipina. I don't like to hold a meeting just for meeting's sake and we don't have something to show for it after a certain length of time. So I do really try to ensure that this collaborative is excuse the word, but a working group, and that you're not wasting your time, because I know you're all very busy and you do this voluntarily. You come together as a group voluntarily from all different organizations that are competitors, organizations that are completely disparate. But in the end, all of that together, right, we're all touching a social determinant of health. We're all touching a social need, a mental health need, a physical need. It all comes together. And that's what we try to do with this collaborative, and provide the direction and the background and the resources as best we can. So appreciate everyone spending the time every quarter to sit here and listen to us and one another.
Yes.
So I'll let you go with that, and have a wonderful July 4th holiday.
Yeah, thank you all so much.
Thank you.
Thank you. Have a good holiday. Thank you, guys.
Bye.